Discussion. My name is Kathy Levine. I'm the Executive Director of UCAN Ohio, a state consumer health advocacy organization working for high-quality, affordable health care for all Ohioans. And we are the lead organization of the Ohio Campaign for Better Care, which is part of the National Campaign for Better Care. I want to thank Dr. Donald Berwick, who's making his way up here, and for making the arduous trip to Cincinnati. We all know how difficult it is sometimes to get airplanes to fly to Cincinnati, to hear about health care in Ohio from the people who know it the best. And I want to thank each of our panelists today for being here. And I especially want to thank each member of the audience for taking the time out of your busy days to come and join us and share your experience with us. It's because of all of you that we do this work. Like the rest of the country, Ohio is at a pivotal moment in the work to improve our healthcare system. While healthcare reform is creating vast new opportunities to improve care, tight state and federal budgets are forcing tough decisions, and the needs of patients and families sometimes seem to get lost in the debate when they should be driving decisions about our healthcare system. That's where the Campaign for Better Care comes in, and the Ohio Campaign for Better Care. We are working tirelessly to ensure that the healthcare reform results in the comprehensive, coordinated, patient-centered, family-centered care that older adults and individuals with multiple chronic health conditions need. At a time when there are persistent disparities in care, when, for instance, African American patients in Ohio have higher age-adjusted mortality rates than white patients for heart disease, cancer, stroke, and diabetes, we are working to ensure that every patient can count on high-quality coordinated care. The Campaign for Better Care is advocating at the state and federal levels for better ways of delivering care. We know that billions of dollars, precious healthcare dollars, are wasted every year in this country on poor quality care that makes patients sicker instead of better. And we know that now more than ever, with Medicare and Medicaid on the chopping block, we must spend our healthcare dollars more wisely. We all know if we improve the quality and coordination of care and refuse to pay for poor quality care, we can avoid the kind of irresponsible and unconscionable cuts that leave our oldest and sickest patients to fend for themselves. That's what we are pressing for here in Ohio. And I thank you all for coming out to support the work and share the exciting work that's going on in Cincinnati. UCAN Ohio is the lead organization for the Campaign for Better Care's work in the state. We're bringing a strong consumer voice to state and local initiatives aimed at improving the quality and cost effectiveness of our care. The campaign is focused on offering consumer perspectives on the many public and private efforts in Ohio, such as the establishment of patient-centered primary care and health homes, patient and family engagement in hospital and primary care, and payment reform so that we can pay for value rather than volume in health care. We are proud to have helped urge most hospitals here in Cincinnati and the Greater Cincinnati Health Council to sign the Partnership for Patients Pledge launched by the Federal Health and Human Services. You will hear more about that shortly. And now it is my extreme pleasure to introduce Christine Bechtel, our MC for this event. Christine is a vice president of the National Partnership for Women and Families in Washington, D.C., a leader of the National Campaign for Better Care, and a passionate advocate for quality coordinated care and robust patient engagement. And she's a real hero of mine as the co-author of the Health Affairs article on the table over there, If You Build It, Will They Come? And I encourage all of you to check it out if you haven't read it. We count ourselves fortunate that Christine represents patients and families on the Federal Health IT Policy Committee, and that she's here with us today. Thank you, Christine.
Thank you, Kathy. And thank Kathy for those great remarks. So I'm really happy to be with you all today and thank each of you for coming, and really want to extend an enormous thanks to Kathy and her team and all of our friends at the Ohio Campaign for Better Care for organizing this really fantastic event today. So Kathy mentioned the Partnership for Patients and the need to make care safer. And right now in this country, but also, of course, in this state and in this city, there are so many priorities in healthcare, right? We spend a lot of time talking about access to care, affordable insurance coverage. So the question is, why do we need to focus now on making care safer, making it better? And the reason is that today, more than 100,000 people die from medical errors in this country. That's absolutely unacceptable. Almost 2 million get infections from healthcare facilities that we're trying to get them healthy, but in fact made them sicker. The costs to the system are enormous, and they're mounting. Now, these are not just statistics. These are patients and their families and their healthcare professionals who are impacted by the stress and the strain of illness and injury that they did not expect nor intend. So we have a real problem on our hands, both in human terms and also in financial terms. And I'm so happy that everybody is here today because you want to be part of the solution. But I want to be clear about one thing, and that is that today is not about beating up on healthcare professionals or healthcare facilities. It's about how we can create change at the deepest levels of our healthcare system. And it's about leveraging the greatest untapped resource in healthcare today to bring about that change. And that's involving patients and families and consumer advocates in actually designing a better system of care that routinely delivers the right care to the right person at the right time every single time. So in the room today, we have some of the most progressive healthcare providers in the country, both on stage and in the audience. These are people who have engaged consumers and families in that redesign of our healthcare system, or some of them are embarking on that journey today. And you'll get to hear their perspectives, and you're going to hear from a number of really terrific consumer advocates who are doing this work as well. And while we don't need evidence to tell us that this is the right thing to do involving patients and families, the evidence does tell us it's an incredibly effective thing to do that really produces meaningful change. And in fact, the Institute for Healthcare Improvement, and you'll be surprised to learn that Dr. Berwick used to lead that organization at this time, IHI, they published an article in 2008 based on their conversations with leaders of healthcare institutions who had produced truly superior levels of change and improvement. And what they said was this. They said leaders of these organizations often cite putting patients and families in a position of real power and influence and using their wisdom and experience to redesign and improve care systems as being the single most powerful transformational change in their history. It's phenomenal. So we know we can create healthy hospitals. That's what the Partnership for Patients is about. We know how. We know it works. And in fact, there's a document in your packet that describes some methods and ways for doing that, and we invite your feedback during the discussion today. But now, for the first time, there is really an incredible and immediate opportunity to advance this kind of work across the country under the leadership of CMS Administrator Dr. Don Berwick and one of his senior leaders, Dr. Paul McGann, who's with us today. CMS has launched the Partnership for Patients, which is an effort that, for the first time, signals a nationwide commitment to reduce hospital-acquired infections by 40%, and reduce hospital readmissions by 20% in the next 3 years. And this pledge, by the way, it's no coincidence that this pledge that hospitals will sign to be part of the Partnership for Patients has a commitment to involving patients and families in making the healthcare system better. So we're really honored to have Dr. Berwick with us today. He's going to kick us off. He is patient-centered to his core. He is a self-described patient-centered care extremist, which I love. I might start a fan club for you on Facebook. And we could not ask for a better leader to guide our federal efforts to really reorient the system around patients and put them in those positions of real power and influence. Then we're going to hear the story of Miss Gloria Smith, who is to my right, and she is going to give us a really great perspective based on her experience as a patient about why the healthcare system needs to change and how patients can help bring about that change. And if you thought it couldn't get any better, it does. We then have a really terrific lineup of both consumer advocates and healthcare providers. So we have Laura Trice and Ken Wilson down to my right. Laura is the medical director for Tri Seniors Health, and Ken is the director of program operations for the Council on Aging of Southwestern Ohio. And then to my left, we have Colleen O'Toole, who is next to Kathy, who is the president of the Greater Cincinnati Health Council. We have Karen Myers, who is an attorney advocate adjunct and past chair of the Family Advisory Council for the Christ Hospital. Thank you for joining us. And we have Norm Warnett, who is the state director and field coordinator for Ohio Alliance for Retired Americans. And we have one panelist who will join us in progress as well. He's on his way, and that's Robert Harris. And we're happy he could join us today. He's the peer support coordinator for the Center for Independent Living Options. So we're going to ask Dr. Berwick to kick us off. We're going to have a great panel discussion, and then we really want to have a discussion with you in the audience, more than just sort of Q&A or your standard Q&A. We want to engage in a dialogue about how we can move this forward in Cincinnati. So please join me in welcoming Dr. Don Berwick.
Thank you very much, Christine, and thank you, Kathy, and you all for the chance to join you today. I'm excited by the Campaign for Better Care. I had the great pleasure of working with Christine at a Campaign for Better Care meeting in Atlanta recently, and it was equally exciting there to see the community and stakeholders coming together, and especially led by the voices of patients and families in the communities that we serve. Let me just begin with a couple of introductions. I'm accompanied by some of my great colleagues from CMS at the back table there, and I want to introduce them quickly. Patrick Conway, who actually left Cincinnati, come to CMS, is now the head of our office of the quality office within CMS. He's also chief medical officer of Centers for Medicare and Medicaid Services. Derek Robinson's next to him. Derek is chief medical officer in our Chicago area. Elizabeth Surgeon is with her, with Derek, with public affairs. And Dr. Paul McGann, whom Christine mentioned. Paul is co-leading the Partnership for Patients, and I'm going to give Paul fair warning. I may ask you to speak up a little bit before my remarks are done, Paul, if I can. You're crucial. What's going on in the Campaign for Better Care and the general framework it comes from is absolutely essential to progress for our country in healthcare because you're building a bridge. You're building a bridge between two essential stakeholder continents of care. On the one hand, our caregivers, professionals, those who organize care, the hospitals, the lay and clinical leadership, the community that tries to give care, and those that also pay for that, like CMS is a payer for care for 1 out of 3 Americans in Medicare, Medicaid, and the Children's Health Insurance Program. So there's the people that give the care. But then there's the communities that are intended to benefit from the care, the public. And these can be worlds apart. They can be continents that have nothing to do with each other, and that isn't going to work. The only way we can get American health care where it needs to go in our nation is with a shared agenda, mutual understanding, and real solid communication between the people who benefit from care and ought to, and the people who give care and want to meet those needs. That's where you fit. In my old job at the Institute for Healthcare Improvement, we used to say that the essential pieces for major change like we need in healthcare are will, ideas, and execution. Will means you have to intend to change or it never happens. Ideas mean you have alternatives. There are better ways to do things than what you're doing now. And execution refers to just carrying out the deeds day by day, making things better. I see patients, families, communities as essential to all three. The will really comes from you. It's your demands, your needs, your voices. You're speaking up for what it is you have every right to expect from healthcare that builds the will socially and politically and organizationally to actually make the changes. Your ideas are fabulous. I've never seen the limit in what patients and families can contribute when they're asked to contribute their ideas and help design care together, not to mention that you're the absolute essential designers of care where it really counts, which is in your homes, in your lives, not in hospitals. You don't spend much time there, hopefully. And then execution is carrying out the day-to-day deeds. It's really being on the case. So when you serve on a hospital board or you speak up in your community, you're working to make things better every day, it's that day-to-day work that counts, and this is essential. Where are we going? In the Center for Medicare and Medicaid Services, what the vocabulary we use now is we call it the three-part aim, sometimes called the triple aim. This is stuff that I started working on before I came there. And it tries to define what we really need to accomplish together as three things at once. One is better care. Better care. Better care when you're sick, the kind of experiences that you're going to hear about from Mrs. Smith as she talks. Think about that as an individual who badly needs our help, and we may succeed in helping her or we may fail in helping her. We succeed by giving her the longest possible life at the highest possible level of function, free of discomfort, and really thriving in the life she wants to lead. Better care for individuals. We help her when we don't hurt her in care, when we reduce injuries in care. She'll describe complications in her care that were unnecessary, that could have been avoided. Helping individuals in care, that's one aim. It's a crucial aim. It's the key aim. The second aim is to keep people from needing care in the first place, because so much of what we bear in our society, in heart disease and stroke and cancer and injuries, these are all caused. They're caused by things not in healthcare. They're caused by what we choose to eat, how we choose to exercise. They're caused by inequities in society. The poverty causes illness. And if we're really going to get serious about health, we have to work outside the healthcare box and really back into communities on health-giving things. All of us have a stake in that. CMS has a stake in that. Hospitals have a stake in that. Consumers surely do. Physicians, nurses. That's the second aim. First is better care. The second is better health. The third is lower cost. Now, lower cost sounds nasty. That's because if you think of lower cost as cost cutting, taking things away, buy less, do less, try less, well, that is bad. That is nasty. When I mention lower cost, I don't mean that. I mean lower cost through improvement. It's what Christine was talking about. It's what you experience in your normal lives. Computers today can do tons more than they could 5 years ago, and they cost less per function. Products and services get better all the time. Better performance at lower cost. Healthcare is the same. What consumers really need to grapple with is a very important idea, which is that better care is the route to affordable care. Improvement is the way to make healthcare in our country sustainable. That's a very important journey. It's a little complicated, and it takes you, interested, curious, involved, to be able to understand and grapple with that and then demand of the healthcare system that it reduce costs through improvement. The alternative, cutting care, taking things away, I don't think it's a good idea. Not in a country that's already spending probably more than we need to on healthcare, 17% of our GDP. We need informed consumers speaking up for exactly the care they want and need with the confidence to know that we can have better care through improvement and lower cost through improvement. This echoes most in the care of chronically ill people, as Christine and the Campaign for Better Care are very articulate about. It's those many of us that have multiple chronic illnesses that are journeying through life with many different burdens, and all of us eventually get to that place as we age. That's where the biggest possibilities are for better care, better health, and lower costs through improvement. If you don't understand how you can get lower costs for improvement, that's important to go to school on. So as you listen to Mrs. Smith's story, think about the cost as well as her own comfort and well-being. Think about what we did to her in the care system that added cost while reducing her health instead of giving her the health she wants. It appears as poor coordination, as ineffective care, as hazards and injuries in care, as redundant work, as disrespect for what patients want and need. What we need now to get to better care, better health, and lower cost in this country is what you bring. I was thinking, listening to Christine, there's two essential resources. They are optimism. You don't try to do something if you don't think you can succeed. So the confidence that we really know that we could have a better care system at a price we can afford, that's crucial. We need a public completely engaged in that optimistic and plausible journey. And the second thing we need is cooperation. This isn't going to be done by anyone alone. CMS alone, as big as we are as a payer, we can't do it alone. Hospitals can't do it alone. Doctors and nurses can't do it alone, nor can communities do it alone. There's only one possibility for the working system to get us to the care we want and need at a price we can afford, and that's doing it together. And that's what's so exciting about the meeting I saw in Atlanta, the meeting I'm here with you today. It's getting together to do it together. We do have a specific case in point right now, and that is the Partnership for Patients that Christine mentioned. The Affordable Care Act, this new law, it's actually kind of two laws at once. The Affordable Care Act is a law we passed to try to help Americans sleep well at night because they don't have to wake up wondering if they're going to go bankrupt from their health care because they can't get insurance. It's a law that says people can have insurance in this country. And it's en route. We're doing that. We're creating an opportunity for people to get health care coverage. We're telling insurance companies you can't deny people coverage because they have a chronic illness. You can't take away coverage when they get sick. We're extending prevention benefits to the seniors in this country. We're expanding access to supported coverage through the new exchanges that will be set up by 2014, where you can find an insurance company that at a price you can afford and with some help if you're at the right income stratum. And we're expanding Medicaid, so more people will be eligible for Medicaid with federal dollars. That's a federally supported expansion. All of that's good. That's great. To me, it's justice. You don't have to worry in America, in the American future, at least 32 million people aren't going to have to worry that they can't get coverage. That's great. But the other law counts too, the other part of the Affordable Care Act, and that's the part about improvement. In order to make the first part successful, we have to improve care. And that means seamless journeys for people with chronic illness, what we're focused on with the campaign. It means safer care. It means more focus on prevention. It means encouraging cooperation. It means paying, instead of paying for how much you do, it means paying for how well you do. So hospitals, instead of getting rewarded for doing more and more, they get rewarded under this law for doing better and better, which means keeping you healthy, avoiding complications. A piece of this law set up something called the Center for Medicare and Medicaid Innovation, and that innovation center has now some of the lead in government for a large government effort to make care safer. That's that better care piece. That's the partnership for patients. It actually has two elements. One element is to make it less and less likely that Americans, when they're in hospitals, will be hurt by their care. What do I mean by hurt by your care? You get an infection in the hospital that could have been prevented. You have a complication after surgery that could have been avoided. You have a pressure ulcer, a pressure sore because you're lying in the bed too long that could have been avoided. A lot of people get hurt in healthcare. The doctors and nurses don't want that to happen. They're not doing it intentionally. But it happens because we haven't put in the kind of care processes that keep you safe, keep you well. Well, we know what those look like. I visited Cincinnati Children's Hospital this morning, and they practically eliminated a certain kind of infection, an infection of a central venous line, a catheter that's feeding you or giving you medicines in a big vein. When I was in training, those infections occurred all the time. But now we know they can be eliminated. They can be done away with. Well, if it can be done at one hospital, can't that be done at all hospitals? That's the idea behind the Partnership for Patients, extending the best we know to everyone. I call it bringing excellence to scale. And the other part of it is keeping you home and healthy when you go home from the hospital. Lots of people, Medicare beneficiaries, when they're in the hospital, they get discharged, they go home, and then they come back in the hospital because they got worse. 20% of patients are back in the hospital in 30 days. When you look at why they've got back in the hospital, it's avoidable. They began to get worse, but nobody noticed it. Somebody forgot to explain their medicines to them when they went home. They don't know what to watch for as a sign of getting worse. They don't have coordinators out there that'll help them stay healthy at home. We think we can avoid a tremendous number of rehospitalizations by focusing on the same idea. If some people know how to do it, can't everybody do it? That's the partnership for patients. The partnership part is key. It's everybody on board. We have now, I think, close to 4,000 partners, Paul, signed up. And you may want to say a word, Paul, about the partnership and who's playing and that vision.
So the Partnership for Patients was announced by the Secretary of Health on April 12th of this year. We're just really ramping it up now within the Center for Medicare and Medicaid Innovation under Don's leadership. And what we're after is for all of you to join with us. Just like Don said, no physician or agency or federal bureaucracy or company or health insurer could possibly do this themselves. And what I've learned by speaking to many, many groups, and I speak to physicians all the time, is that central principle that Don explained to you, the principle that we can actually save cost by giving better care, that better care can cost less, that principle is very difficult for most physicians and hospitals to understand. And I've started then coming to groups like yours and talking to people like Christine to get that message across, because I find that your groups, the people that are involved in the front line and patients like Gloria Smith, understand this all too well. The needless readmissions, the needless rework, the physicians and systems that aren't listening because they think they're too busy, you can help us with that in the Partnership for Patients. And so we're going to take this to the road. You're going to see a lot of resources put into place to help doctors and physicians and hospitals get on board with this campaign. And we're really going to ramp this up over the next 2 to 3 months. And we'd like to join forces with you and with Christine and other organizations. And she just told me, I was talking to her before, that you already have people that are already active in the communities. We'd like to recruit you to this national effort. And I think together we can make rapid progress in the United States, even in the next 6 months.
Thanks,
So
Paul.
Thanks very much, Don.
We've set some pretty bold goals in place. A 40% reduction in what we're calling hospital-acquired conditions. Think of those as complications. A 40% reduction in complications to patients that happen in hospitals, better care, lower cost, and a 20% reduction in that readmission thing, where people bounce back in the hospital after they go home. These are achievable, but they're only achievable if we really go for it, if we really intend it, will, ideas, and execution. And the voice of the public, the voice of the community, families, and patients is going to be absolutely key here. Keep that in mind as you listen to Mrs. Smith's compelling story. Let me just close by saying it's not the only game in town. The Partnership for Patients is very exciting. It's large. It's $1 billion investment in helping hospitals and clinicians all over this country bring excellence to scale. But in the Affordable Care Act, the new law, we have lots of other opportunities now to make care better through the Innovation Center and otherwise. We can now pay for bundles of care. Think about that. Instead of paying for the operation and then for the follow-up visit and then for the medications and then for the diagnostic tests separately, we can bundle them all together, which makes people start to think, I wonder if there's a better way to do this now that I can move the money around. Maybe I need a little more home health visiting and a little less blood testing. Figure out the right package and we're going to have better care. We have accountable care organizations in formation. These will be organizations that can actually get your back. They can take care of you over time and space, and you could still go anywhere you want. You're not locked into any network at all. We have medical homes and health homes. These are new formats for payment and organization of care, so you have a number to call when you have a question instead of being lost in a very technocratic system. As I said, we can change payment now and reward hospitals for doing better care, for safer care, more effective care, and the same will go for doctors, and the same will go for home health and for nursing homes over time. And we can be more transparent. You, as communities and care consumers, you can know what's going on. We're going to turn the lights on and let you see what the performance of organizations is. How well are they doing? How safe are they? What are the readmission rates? What are the complication rates? And if we do this together with the caregivers, all of us together, they will learn, caregivers will learn, and you will have choices. You'll be able to look and decide what it is you really want and what you're going to insist on. Very exciting time in healthcare. It's fraught. It's difficult. There's a lot of contention. You're reading bad news in the papers. I know that. But please have hope. We really are in a position now in this country to get to the care we want and need. Better care, better health, and lower costs through improvement. The more you understand as consumers of care, as families, as communities, the better this is going to go because you can speak up for what you ought to have. I'll leave it there, and I'm anxious to hear Mrs. Smith's story now. Thank you.
Thank you so much, Don. Your remarks are always so inspiring. I think in the inspiration department, Ms. Gloria Smith is going to give you a run for your money. So we will turn it over to you.
Thank you all. I hope all of you can hear me because of the lack of care. This is where I talk. I'm not ashamed of the way I talk. I'm just thank God I can't talk. So, and I would like to say hello and thank you all for having me here today. My name is Gloria Smith, and I must apologize for the hoarseness in my voice, but I shouldn't. And I hope I can make myself heard because I have a lot to say about my encounters with the health system, including the one that left me like this. And I hope that sharing my story can help people get better care every time they need it. And I was born here in Cincinnati. I have 4 wonderful children, which one is here with me today. And I have 11 grandchildren and 9 great-grandchildren. And then I am 66 years old, And because before I was 30 years old, I became really ill, didn't feel good, very good. And I kept going to the doctor. One took a biopsy without making me feel better before she took it, which left me really sick and knocked out. I was passed out. And another doctor came in, and he took another biopsy, but he put me down like I was getting surgery. And he found out that I had labia cancer. The other doctor didn't find anything, but the second doctor found I had cancer of the labia. In other words, the one doctor didn't seem to care. She was just doing her duty. That's what I felt at first, after the other doctor found cancer. And the doctor who operated told me that they removed all the cancer. I didn't have to have treatments, which I was blessed not to have treatments, because we went beyond the cancer and then went into my lymph nodes. And so I considered myself blessed. So I went on with the life. I raised my family. I worked in retail. I trained to be a nursing assistant. I worked with the elderly off and on for 20, 30 years, which I was blessed to be able to do. And as I moved among different employees, I also had to see many different medical practitioners. But the thing is, between the time I had my first labia, my first cancer and the second cancer, I was sick a lot. One doctor would send me to get a CAT scan. They didn't see anything. Another doctor would send me to get x-rays of my chest. They never saw anything that was wrong with me up to my second cancer. But in the early 1990s, I started feeling really, really sick. And the doctor that I went to then, actually I went to the same oncologist, and he told me that I had cervical cancer. And when I got that operation, he went beyond that point, took out my lymph nodes and other areas, and got all the cancer. I still didn't need treatments for this cancer, which I thank God that I didn't. And but then through the 1990s, I continued to work as a nursing assistant. But in 2 instances, I lost jobs because of other illnesses that they didn't detect that I may have had. But I feel like if they saw that I had cancer before, they should have checked to see if I had cancer again or something that would lead to the cancer. But they didn't. And then by 2002, I ended up with cancer again. And I had a mass in my right abdomen, which had been there for several years. But they never detected that mass in my right side, which led to ovarian cancer. They got the cancer again, which I didn't need treatments for. But I thank God that he was able to let the doctor reach in and make sure I didn't have cancer growing again in my body at that point. But by 2005, well, I would like to say that in 2002, before I had my surgery, after they told me I had the cancer, I was smoking up until that point. So I figured maybe I need to quit smoking. And 2 days before I had my ovarian cancer, I threw my cigarettes away. When I came out of the hospital, I didn't smoke another cigarette. And to this day, I don't even crave cigarettes. I praise God for that point. Thank God for that. But I do know that as far as smoking, I was without smoking for up to this point, about 10 years now. It's been quite a few, about almost 10 years. And thank God for that. But I wasn't smoking when I ended up with laryngeal cancer. I had stopped smoking about 4 or 5 years up to that point. Excuse me, I'm a little bit nervous. Excuse me, please. But in 2005, I started getting sick again. And I went over to the urgent care here in Cincinnati and Clifton. And the doctor gave me something to swallow. And he saw the blockage in there. But he didn't send me to get any treatments or to find out what caused the blockage. And I kept going from one doctor to the next. I kept getting sick again over and over. So finally, they gave me a nuclear test, where you take this little pill and it's in the little metal container. I drank that, and it was it's like a radiation. It's so much radiation in it that they had to give me a card that stated if I went in front of a medical detector, I had to present that card. That's how much radiation was in it. And I had to carry that for like 2 weeks to a month. But when I went in there and they took that test, they didn't tell me anything for about 2 weeks, and they said I may have a goiter at that point. But when the thyroid, I'm nervous. They told me I may have a goiter, okay? And I kept going from one doctor to the next. The one doctor I went to, Dr. Freeman, well, I shouldn't have called his name. Another doctor, I went to him, and he wouldn't tell me. He told me, he said, yeah, it looked like you might have a goiter. But he never did anything about it. He never told me what I should do. He never gave me anything to take, any medicine or anything to take for that goiter. And I was pretty upset about that. So I quit going. I mean, I kind of went off on him, a little bit before I left, which wasn't nice, but he wasn't taking care of me at all. And so I left him, and I just kept him. By March of 2008, though, I couldn't breathe. And between all that time, no matter where I went, I had to stop and sit down because I couldn't breathe. I didn't have enough breath in me to get to the next point, it was horrible not breathing, not being able to breathe. So one morning I dropped my daughter off at work and drove around, said, you need to go in there and see about yourself. But I didn't have no confidence in going in there again in an emergency. I really didn't have any confidence at all because they always told me my blood test was clear, my x-rays was clear. They can't find anything wrong. I was at temperature of 104. Been in the hospital a week. We can't find anything wrong. I mean, it's horrible when you can't breathe and don't have the confidence to go inside to see about yourself again. But when I went in there, I was blessed to get a doctor that saw me on. He just looked at me and the way I was breathing, saw the results of my pulse ox, my O2 test. It was like below 85. It was really low, and I know it probably was going down as I was sitting there. So he gave me oxygen. He put a probe down my throat, and he was whispering with the other doctor, which I assumed and I knew. He was telling them I had probably got cancer down in here. But before that night I was operated on, and I ended up with a trach in my throat. And they had removed part of my larynx and my voice box. That's why I can't talk today. But before I went to the doctor and was almost talking like this before. I went to emergency, and I was going to doctors talking like this, and they never fit. They never checked to see why my voice was like this until that day when I couldn't breathe. I'm sorry. But before that night was out, I had some really good doctors because they operated on me. They took that out. But the next day, when I woke up, I was just feeling much better because somebody was concerned enough about me to check and see what was wrong with me. And it took cancer of my larynx and about to lose my voice. I didn't talk for several days. I could not write on the paper. And then I found out I could take my finger and stick it on the hole because I remember when I was working at the trach hospital, I worked with patients that had trachs, and I cleaned their trachs and stuff like that while I was working. So I was able to take care of myself. I didn't have to have nobody help me with that because I already knew what to do. And I found out as long as I could stick my finger on my trach, I could talk. They told me I wouldn't be able to talk for 2 years, that I would wear that trach for 2 years. But bless God that I only wore the trach for 6 months, which was a blessing to me because, and the doctor, when he took it out, he said, you will not be able to talk for 2 years. And I was blessed to say, how many years did you say? This was without the trach. So I knew I had been blessed in the end because I finally decided I'm going to do this. I'm going to speak up. And I told the other doctors as I go, they had me coming every week. And I had to take radiation for 35 days. But they had me coming back to see them every week for about a year, 2 years. And now I only see them every 6 months because I don't have any more cancer. But I did get the chance to speak to everybody I got a chance to. Speak up for yourself. Tell them doctors what you need. Don't listen to them. Because, sometimes they really, I think sometimes they care. But sometimes, I'm trying to be nice. I think they try to they be overwhelmed sometimes with the patients that they have. And, they can't get to you sometimes. But when they see that you're obviously sick, I think they ought to take time to take care of you at that point. If they don't even have you come back, take care of me now. And I'm really trying to get people to see, even though the doctors make mistakes, but you got to stand up for yourself and advocate for yourself and go in there and demand what you need. Because otherwise, you're going to end up like me. Don't do it. Like my daughter here, she almost had an operation last month under somebody else's name. So you really have to speak for yourself. And that's what she did. She was really angry about it too. But I appreciate everybody listening to me because you really don't have to go under because somebody don't want to take you where you're supposed to go. You can still come out on top. As long as I have breath in me, I'm going to speak up. I'm going to talk at all times. And I'm glad, and I appreciate all of you that came up and hear my story because it's true. And there's way more than I told you. But I think this should be enough to let people know. Thank you.
What a powerful testament to a lot of lessons, right? Lessons for the healthcare system about paying attention and literally what is the meaning of taking care. And lessons for what happens and how patients can get better when they're empowered, when they know what to do and how to take care of themselves, and when they have a relationship with their healthcare providers and they have a way to navigate the system. And I think what is so meaningful and the reason that we wanted Mrs. Smith to talk today is because she's right. We do need to be advocates for ourselves. But it's also not enough to rely on each of us in the healthcare system to just be an advocate for ourselves. We have to be able to change the system of care so that it can advocate for us too. So I think that's really powerful, and I just want to thank you so much for being with us today. So we have now some wonderful community examples, both on the consumer side and on the provider side, who are beginning to really change the way we think about healthcare. And we've asked our panelists to speak for a few minutes on each, and then we're going to want to get into a discussion with you where we can explore them in more detail. So we're going to start with Dr. Laura Trice, who I introduced previously, and she's going to talk about the Cincinnati PACE program, which is a really interesting, great model of care.
Thank you. First of all, Dr. Berwick, I want to thank you for your interest in PACE. I know you visited our Philadelphia PACE site this past year, and also thank you for your support of PACE expansion. We are a community-based program. We deliver comprehensive but accountable care for frail elderly. And we are 100% responsible for both the cost and the quality of health care that our patients receive, no matter what the care setting, no matter if they're in the hospital, nursing home, if they're at home, if they're in hospice. We provide all their care, we pay for all their care, and we monitor the quality of all their care. I think specific to today's discussion, I want to talk about how we promote the engagement of patients, families, and caregivers in their care. So I'd like to give you a few examples. Before we even enroll a patient in our program, they are required to review our care plan. The patient, the family, they review our care plan, and they sign off on it. They agree to it. And they regularly re-review it at regular intervals. We have a very active patient advisory council. So our patient advisory council is highly involved in our operations. They give us a lot of good suggestions. Over the past year, they wanted more computers added to our 3-day health centers. They are constantly giving us input about the quality of the food, both the quality and the variety of the food that we deliver to them in their homes and that we provide to them in our centers. We have an active patient concern process, so let me explain that. Any patient or family member can voice a concern to us about their care, either verbally or in writing, and they can voice that to any staff member, and we are required within 72 hours to address that concern. Looking back over some of the current concerns I've had over the past couple of weeks, I had a daughter who called me. She accompanied her mother to a cardiologist. Now, this would be a cardiologist that we contract with. He's our provider. He's on our panel. And this daughter was quite upset. She told me that the cardiologist did not touch her mother or get out his stethoscope when he examined her. And I don't know about you, but I don't just think that's an expectation of elderly people, that when you go to a doctor that they touch you or use a stethoscope. So I was very concerned about that, and I had what I thought was a very fruitful discussion with the CEO of that cardiology group. That discussion went something like this. He said, that's not the first time this has come up about this cardiologist. I want to let you know that we do have a list of cardiologists that we think are very patient-friendly, and we're going to talk to this person, and this is going to actually be on our staff meeting for QA. So that made me feel pretty good. I can't solve every concern that patients throw at me. When it's about food, I'm very happy to turn that over to our lead dietitian. I had a lady this week call me. She wants to always be the last person picked up on the van ride coming in and the first person dropped off. So I didn't know quite what to do with that. I was very happy to turn that over to our transportation supervisor. In closing, I just want to say it's really an honor to be asked to be a part of this panel as a physician. I started out in healthcare over 30 years ago. I started out as a hospital nurse when I was 20 years old. And I would have never believed what's going on now, all the work we're doing with healthcare. If somebody would have told me when I was a 20-year-old nurse that patients and families could look at their medical chart from a computer in their home, I would have never believed it. But that is what's happening. We've had electronic medical record for 4 years, and there is the capacity for our patients and families to look at their medical record. I look at my own medical record from my home from my TriHealth PCP. So that's amazing. And when I was a nurse in the hospital, when we discharged a patient, we were done with them, weren't we? We didn't feel the need to follow up. And, that's not a good idea, is it? I mean, we hear that's not a good idea. We don't want people to stay longer than they need to. We don't want those readmissions. So I'm very encouraged by the work being done in the city. TriHealth has a CHF Navigator program where there's a nurse assigned to call and follow up on every discharged patient with CHF. We're trying to expand that into other areas. So I'm very encouraged. And I thank you for asking me to be part of the panel. I'm looking forward to the other members and what they have to say.
Thank you. Thank you. So now we're going to hear from Ken Wilson from the Council on Aging of Southwestern Ohio, and you're going to describe, among other things, the transition program that you all run.
Yes, thank you for letting me be part of the panel. And I'm going to briefly tell you about Council on Aging and what we do and our exciting new Care Transitions program that we've implemented here in Cincinnati. We're an area agency on aging. We serve a 5-county region, and we administer the Passport and the Assisted Living Medicaid waiver programs designed to keep people at home instead of going to a nursing facility. We also administer local senior service levies called the Elderly Services Program. All combined, we're serving 20,000 older adults in their homes and their communities across the 5-county region. As an area agency on aging, we provide care coordination to all of our clients. So it's a social worker or a nurse that's having regular visits into the home to make sure that the right care is provided in the right setting at the right cost. Our goal is to keep people independent at home as long as possible. Community-based care is very cost-effective. The cost of community-based care provided through the Passport program costs on average $1,200 a month, compared to $4,200 a month for nursing home care. And many people are surprised to hear that in Ohio, over the last decade, the population over age 60 has grown by 15%. Yet over that same time period, the population of people over the age of 60 in nursing facilities has declined by 15%. And there's a direct relationship between providing care in the home and expanding these programs and decreasing the utilization of nursing facilities. We began a care transition program with 2 goals in mind. One goal was to reduce re-hospitalizations. As Dr. Berwick discussed, 1 in 5 patients are readmitted within 30 days of leaving the hospital. That's 20%, 30-day readmission rate. We also know that 60% of all long-term nursing facility placements begin with an admission from a hospital. So our goal is to reduce unnecessary long-term nursing facility placements. We implemented the Eric Coleman Care Transition Model, which is an evidence-based model. And we're operating currently at University Hospital and at Christ Hospital. And we submitted a grant application to CMS last month and are hoping to be able to expand that to many other hospitals and a broader population. The process includes the care transition specialist doing rounds of the hospital, meeting the patient in the hospital, and going over their health record with them, their personal health record, followed by a home visit upon discharge. And during the home visit, they go through their personal health record and make sure that they understand and take responsibility for their own health care, that they make an appointment with their primary care physician, and that they also reconcile their medications. And we found that 90% of the clients coming through this program need help with medication reconciliation. We also teach the patient about their red flags so that they have a plan in place when a red flag presents itself so that they don't end up back in the emergency department. And then we also have a handoff with our care managers for community-based care and ongoing follow-up. The results so far in this project have shown a 7.5% 30-day readmission rate, which is very impressive, and we're looking forward to seeing the longer-term results on continued diversion of people from inappropriate nursing home placement. Thank you.
So now we're going to hear from Colleen O'Toole from the Greater Cincinnati Health Council. We'll shift our chairs over to look to my left, your right. And Colleen is going to talk about transitions as well and involving patients and families.
Thanks, Christine, and thanks to all of you for being here. It's an honor to share the stage with such a prestigious panel, and thanks to Dr. Berwick for visiting Cincinnati and showing support for the collaborative efforts that are already ongoing here. Hopefully, in partnership with CMS, we'll be able to continue our work even and spread it even further. I'm representing an organization that is comprised of area hospitals in the tri-state region who believe that by partnering together, they can improve the delivery system in ways that no individual one of them can do on their own. Their work focuses primarily on improving quality, improving access, and improving cost effectiveness, as well as improving community benefit. The hospitals could do a lot of work together, but they also believe that they alone cannot improve things to the extent that they can by working with other partners in the community. Major partners include the Health Improvement Collaborative, Health Bridge, HCAN, the health departments, and others in the community who have an impact on the goals that we're trying to seek, the triple aim, as Dr. Berwick announced previously. I just wanted to touch on 3 areas that I think are of interest to the Campaign for Better Care, and in particular relevant to the Partnership for Patients. Those 3 areas have to do with reducing harm, improving care transitions, and enhancing the involvement of patients and families in care. The Health Council has experience in supporting collaboration to reduce harm. We've had a number of projects that have focused on reducing infections, standardizing processes across hospitals so that practitioners, physicians, and clinicians can experience the same practice in different hospitals and be less prone to error. Based on that, we have initiated a harm reduction program that is in line with the Partnership for Patients. The Patient Safety Committee has decided to start with focusing on decreasing falls and decreasing pressure ulcers. In that vein, they have agreed together to decrease by 50% both of these areas by 2012. This is a project that involves standardizing definitions, implementing standard metrics, and monitoring over time. So we're pleased to be involved in this. We're pleased with the number of hospitals who have signed the Partnership for Patients, and we look forward to the involvement of other partners in this work. In terms of care transitions, Ken mentioned one that the Health Council and its hospitals are a partner in with the Council on Aging. That's the proposal to HHS to be one of the designees for the care transitions contract. But in addition to that, because we have in this community another federal program called the Beacon Program, the primary recipient of which is HealthBridge, our regional health information exchange, we have the opportunity to work together with a number of other organizations to reduce readmissions and improve care transitions. We are pleased with the work that we have so far. That work involves that fact that we will decrease readmissions by CHF patients in the pilot project by 10% by the end of this year, and further beyond that in the course of the project. We believe that only by these kinds of partnerships can we make the kinds of improvements that we've begun, and can we spread them. And finally, with regard to involving patients and families in care, we could do none of this without the input of patients and families, and we have had the involvement over time of them in our projects. A new initiative that was started several months ago is one where the hospitals are jointly sharing information about how to institute family and patient councils in each of the participating hospitals. There are models for the way we can do this. We have great models in this community, and we have great models nationally, and our hospitals have agreed to share best practices on how to implement those councils, what to measure and monitor over time so that they've made a difference, and also so that we can spread the work beyond our Cincinnati community and share it with the rest of the country. So I look forward to talking with you all about these 3 areas and learning more about the way that all of you and we can partner together to improve care for the residents of Greater Cincinnati. Thank you.
Thanks, Colleen. So next we're going to hear from Dr. Karen Myers, who is an elder care attorney, and she's going to talk both of the work of the Family Centered Care Council, but also about her own personal experience as a caregiver for her mother.
Thank you very much, Christine, and thank you for having me on the committee. I always start a speech with, I'm here because my mother made me. And that's an absolutely true statement. In 2005, I received a call from a hospital saying my mother had been admitted. She had a bleed in the brain in 3 areas. She was in a coma, and she was dying. So obviously, we rushed to the hospital, and I will tell the rest of the story integrated with family-centered care. But I will tell you, 3 days ago, we celebrated her 86th birthday, and she was with us. So, having said that, in a follow-up business, she ended up on a vent for 30 days in the hospital that Russell Dean, who's in the audience, ran. And I cannot say enough about that LTAC hospital and what they did to save her life and how they integrated the family. My cousin Laurie, who's in the audience, is quite an accomplished musician. She was allowed to bring her guitar while Mom was in a coma and play the guitar to her and sing to her in the hospital. That meant the world. And when Mom woke up, she remembered Laurie singing. Now, thank God she didn't remember me singing. So having said that, in a follow-up business with a pulmonologist, there was a sign on the office wall saying Christ Hospital was starting a family advisory council, and if you wanted to apply, call this number. So Mom is blind from her accident. I read that to Mom, and she said, you should call. So I called, and the rest is history. I was lucky enough to be a founding member of the Family Advisory Council at Christ Hospital. That was facilitated by Sue Dickey, who's in the audience and is still our administrative coordinator. That committee, it's incredible. We have reviewed 40 processes and brochures before they were implemented. In other words, the family was asked, will this work? What's good? What's not good? How can we improve it? Before it's ever started. 40 times we've been asked that. Our members serve on 30 committees. Unbelievable input we are given on a daily basis in that regard. We participate in the building committee, the ethics committee, the geriatric service committee. And from this committee work, I've learned two things. The families are the gestalt of medicine. They are the observers of the psychological and physical changes in the patient and in themselves. That gestalt is incredibly important to the curative nature of the outcomes. Equally importantly, we've learned in that process about communication barriers. And this is beyond the scope of this discussion, but let us say that it never does any good to tell a doctor, hey, you idiot, you're not listening to me. But it does do good to say to him, I can understand that you may see this differently than me, but I need to tell you what's going on from my perspective. There's a communication model that's a bias buster. And bias comes from two areas. It comes from education, and it comes from tradition. I once had a judge call me Goldilocks during a hearing. The way to address that is not to say, Judge, you're out of line, but to say thank you for the compliment. And so the reality of communication and bias busting is something that I hope the medical schools will embrace, and they will go forward with that. Having said that, I want to mention just two things from client issues, because I deal a lot with clients. The readmissions are a depressive cycle for the elderly. There's no question about it. And there's no question that information in the exchange that Ken just meant and the Council on Aging is working on with the hospitals will help. If Mom has a red spot on a particular part of her body and it starts to get worse, it's very important for the family or the patient to say, now, hey, this red spot's getting worse, before it becomes a stage 2 or a stage 3 wound. Having said that, there's so much we can do with that kind of thing, and the Family Advisory Council at Christ is definitely working towards that. I'm going to end with a thank you to Steve Moeller, who is Dr. Steve Moeller. I should be more respectful in my comments, but he has done a tremendous job of integrating Family Advisory Council in medicine. He sits on the Advisory Council with us. He's a great caregiver for Mom. Having said that, I'm going to two brief stories. This is an email from an elderly client who is nursing home, has no family here. We installed Dragon on the computers of the elderly often. And Dragon is a way that they can talk into the computer and it will translate. And here's an email I got from her. The powerboat that you talked about worked well. I meant empowerment. I didn't talk about a powerboat, but the powerboat that you talked about worked well. The pink purple pill I'm getting is okay. It's just different than the white pill because somebody else made it. Thank you. Then let me give you a second email, and this is from a doctor in Nebraska. Your client is in our hospital. and asked for a council meeting. We didn't know what that was, but she described it, and we got several physicians together and the social worker, and we now have a transition of care plan. Thanks for the labeling. So having said that, there's no end to what we can do. And if we work together, we can solve these healthcare problems. This is a squeezy, a stress ball that Mom and I give out when we go out and talk, and it says respect is key. And we believe through respect, anything is possible in healthcare. Thank you.
Thank you. So now we're going to hear from Norm Ornette, who's going to describe the experiences that retirees have shared with him about some of their problems with patient safety, care coordination, and transitions.
I'm Norm Ornette with the Alliance for Retired Americans. You might know us as the Old Council of Senior Citizens. We were glad to partner when the Campaign for Better Care came to Ohio because retirement is based on having any kind of quality retirement is based on having good quality health care. Having kind of access and some kind of engagement is a way to begin to secure a retirement that means something, that has some value. I know I'm just starting out on that edge. I got my Medicare card this year. It's rather odd. I was a social worker dealing with older adults when I was 22. I kind of look back at that time and wonder, what in the world did I say to folks? You get a little edge to you. I want to share with you some quotes that have happened to me in my journeys around Ohio. This is from Dick Gilbert. I would really prefer not to be a pincushion from my 5 doctors when one blood draw would be sufficient. From George Tucker, who had his saliva glands removed. They were cancerous. You all got to get along and share. One single set of tests every month is enough time out of my month. George is still working, and he's 68. So this is from Al. I see 15 doctors, and these are all the medications that I get. It was a table 4 by 4. And I asked him, do the doctors talk with one another? He said, no. We had a little talk about how to make that happen. Jess Johnson, he's a friend who used to work as an x-ray tech in a hospital. My job as an x-ray tech was to do post-op checks to make sure there was nothing left inside. And this was from a hospital, president of a local union in a hospital. Our members show signs of TB because the ward is not isolated from the rest of the hospital. The HVA system covers multiple buildings as have not been sterilized or purged in years. Just a reflection on the kinds of things and the kinds of issues that both workers who are active and workers who are now retired have encountered in their experiences. One of the things that comes to my mind is sort of that time in my former career as a labor research director, and my job in that capacity was also to promote labor management quality relationships. We get through, as you described, building sort of a quality council. There's a period of time where people fetch and sort of go through that period of getting the venom out of the system. But then there's the time of real work that can be done. I experienced this in a public sector system where the system had fallen apart. It was a sanitation system, and the costs were driving it literally out of business. The city couldn't pay for it. The workers and the management got through that period of fetching at one another, figured out how to sit down and talk with one another civilly, and actually dropped the cost to the consumer with a reduction in the workforce by half, from 24 to 12, purchase of new equipment to do the job, and drop the cost by 37% in a 2-year period of time. That's the kind of engagement that I envision to see patients and families and the provider network and the payers begin to sort of get to so that we can begin to drive cost and build a better system at lower cost. And that's part of why I'm here and wanted to participate in this. So thank you very much for your time.
Thank you. And finally, we have Robert Harris from the Center for Independent Living Solutions, who's going to talk about some of his personal experiences with the healthcare system and why it's critical for older adults to have a voice.
Well, first of all, I want to thank everyone for coming out today, because I tell you, without you, it can't happen. It cannot happen without you. I am an advocate. I have been an advocate for about 50 years, and I can't stress too strongly that as we have met today, I hope that everyone can exchange names. I hope there's a roster that we can have, and that the UCAN people and all those other folks really, really push diligently to keep us together, keep us informed, keep us moving, because we have the power, but we do need to be coordinated. Also, just kind of a little bit of levity, but a little bit of a strong need, is that I see that there's a cue card person in the back. I cannot see 65 feet away. So please come within, 10 or 12 feet. I would appreciate it. Let me know, because I have no idea what the card says. I am with the Center for Independent Living Options, and I am just, again, happy and delighted to be here. I am going to say some things that may offend some of the doctors and physicians and healthcare people. It's not intended to offend, but it has been my experience, and it's just real. First of all, I'm going to tell you the story of my mother, who died 6 years ago. She had a condition that caused her to need blood transfusions constantly. Well, not constantly. I mean, every month and a half, 2 months. And she was 85 years old. And she went into the hospital, and they said to get a regular transfusion, they said we needed to keep you. They kept her. I went there that night. She begged me to take her home. I said, Mom, Mama, they need to keep you here and help you. 3 days later, they called me up to say, come and get her, which I did. And at that point, she was just as doped up as you could ever think. She didn't know who she was. She was slobbering. She was in the back of a car, a friend of mine who picked her up for me. We got her home. That night, a few hours later, when my son came home, he decided to help her in the bed. He took off her socks. Her feet had turned black. Her nails were white. We rushed to call the ambulance, rushed her back to the hospital from which she had just been dismissed. And when I got there, because I couldn't ride in the ambulance with her, and I had to take a bus, she was still waiting. And that was at least 30 minutes, maybe 40. And then they finally, after I pitched a fit, which I did, they took her in, took another 20 minutes to have someone see her. They saw her. They started talking about amputating her feet. I knew my mother did not want that. I said no. 2 days later, I found a place to put her in, a nursing home and a hospice. 30 days later, she was dead. And this is, yes, 30 days later, she was dead. And she would have died that night if I had kept her at home. And I thought about that afterwards, whether I should have done that or not. But this was a crazy, ridiculous thing. She had just been dismissed from that hospital. How can you do that? She had just been dismissed. I had a circumstance years and years ago, 25 years ago, with my late wife, Gloria. The system would not believe the things that she needed. She had sarcoidosis. She had it from a very early age at 12. It left her with only 1/2 lung capacity, and, consequently, she died. And I knew she was going to die. She knew she was going to die. But the thing that I had problems with was the way the medical system handled it in the hospital. First of all, she had been unconscious. We revived her. After she was revived, they had her on a ventilator in order to keep her comfortable. They sedated her so she could not talk to me, didn't know I was in the room. Most of the time, I'd ask her physician to, when he did awaken her, that he called me so that I could speak to her. He took it upon himself not to do that. He did revive her. He did talk to her. Then he put her back into that kind of sedated condition, and she died later on that evening after they told me that they had talked to her, and I never had a chance to talk to her. And then afterwards, about a week afterwards, I got this neat little letter that said, from the cardiologist, that said, your deceased wife's bill is, and we want you to pay it up. You know, unfortunately, I have not had a great experience with the system. I am 65 years old, or I will be on the 27th of this month, God willing. I contracted meningitis when I was 8 months old. Doctor said at that point I would be dead in 3 days. After I didn't die in 3 days, they said I would be mentally retarded. We're now getting rid of the retarded word, the R word. They said I had low IQ, would have low IQ, cognitive disabilities, would not be able to walk. I ran temperatures of 105. They said I would not be able to see, and I would not be able to hear because it should have burnt my system out. And I'll tell you, at 65, all of those things are beginning to happen. And eventually I will die. There's no doubt about that. But in the meantime, I really do push that we really fight, and we need to have patients involved. We need to have doctors involved. We need to have caregivers involved. And I have a message from a nurse friend of mine who says that we really need to just throw away the current Medicare and Medicaid system and start all over again, because it does not work. It does not work for providers. It does not work for the patients. And I dare say it doesn't work for physicians who want to make it work either. And I've seen that myself. These chairs and things of this nature are tremendously overpriced. They're like 5 or 10 times the amount of money that it actually costs the manufacturer to produce it. I'm riding in a $5,000 vehicle right now. It doesn't cost $5,000 to make it, but it will cost you $5,000 to buy it if you buy it through the organizations. And someone has to pay for it. So even if I don't pay for it myself, it's still being paid for. So I know my time is over with. I know it was over with some time ago. But being an advocate, I ignored that and kept talking. You know, so, thank you.
All right. So we had a lot of fun. And we've run a little bit tight on time, and we committed to a 2 o'clock end. So what I'd like to do is ask you guys to offer up questions or feedback in 2 ways. One is, let's go ahead right now and do as many sort of questions and discussions as we can. But then we'd also like to invite you to stay and talk and network with each other afterwards as well. So we've got some microphones that will rove in the back. So if you want to raise your hand and there's a question or a comment in the front and also in the middle.
Hello. I'm here as a caregiver. My dad passed away just a little over 2 months ago, and I have an 85-year-old mother with dementia who lived in Florida. My father was her caretaker for 66 years. Moving her to Ohio has been the reason I'm here. Someone suggested I come to tell my stories, and I'm not going to go through my stories because time is really, there's not enough time for me to tell you what's been going on. But what I'm listening to and hearing from you are all talking about the patient in the hospital. What about the patient who's not in a hospital? I don't know any of your organizations even exist. I don't know anything about your program, the elder care. I hired an elder care attorney, which was suggested by somebody, just to get me through the systems, the veteran system, the Medicare system, the Medicaid system. My mother's insurance in Florida was canceled the middle of July, but new insurance would not start until the 1st of the month. But her medicine expired. The doctor in Florida terminated her as of August 1st because she was no longer a Florida resident, and my mother, who takes Lexapro, was not given a prescription until 9 days yesterday, until I could get a doctor to see her, once her insurance became approved.
Yeah.
That is a system you guys have to work on, you have to think about, because if my sister didn't take Lexapro, my mother would not have had medicine for 6 days. I gave her my sister's medicine, who mailed it from Connecticut.
And unfortunately, I think that story is all too common. So let me take a shot at actually giving you some of an answer here, which is what we're talking about is really having consumers, patients, families, advocates involved in redesigning the entire healthcare system. At the same time, we have a unique opportunity in this incredible initiative that begins to connect the hospital with home and community-based care. And so that is in part why we want to focus on that. But it's absolutely applicable. And we've got great examples across the country where consumers are helping to redesign primary care and specialty care. So there is a lot going on. I want to reassure you of that. But what I think your point is that there is an incredible urgency. And I think we hear that. Absolutely. So there's a question here.
Before you go to the next question, can we give Dr. Berwick a chance to make a few closing comments before he heads to the airport?
Would you like to do that?
Yeah, thanks.
Sure.
I apologize, but I have a plan I've got to make, and they won't wait for me. I hear the passion in your question. We have a fundamental problem about continuity of care in our country. We built a healthcare system in fragments, and you're a victim of that. And you could happen in a hospital, it can happen between hospital and home, or it can happen if you never go into a hospital. So you're absolutely right. The good news is, I think we all know that now. That is the sense of urgency about fixing it has risen, partly because we have testimony like yours, and partly because we know it's connected to cost, and cost is crucial. What could have gone wrong with your mother would not just have hurt your mother, but it would have ended up with a vast expense possibly that we could have avoided if we're just smart thinking front. It's going to take change. That's the point. The reason you're suffering is because we have a legacy system that doesn't work anymore. It's built in fragments. So you said you guys got to fix it. I say we guys got to fix it. It's all on board because this is going to be a massive amount of change. Hospitals thinking differently about what they are. My friend Rosabeth Moss-Cantor, who is she's a professor at the Harvard Business School, she's fond of saying we need not just to think out of the box, we need to think out of the building. We need to start thinking about the whole system, as Christine just said. And it's going to take your will and your voice and all of us working together to do that. The dislocations are there. This is going to be hard because hospitals and doctors and nurses and patients and everyone's got to change and think about teamwork, continuity, the kind of interaction and commitment to reliability that you now can hear in all the voices up here. So we're on this journey together. It's going to take will, and we really need your voice. That said, we really can do it. We have good examples. I could name you communities in the country where that wouldn't have happened to you, and I think we have to understand that now's the time when excellence got to be the norm and get on that road. So thanks for speaking up. And thank you all for your working together, and you, Christine, for your organization. It's a marvelous place. I wish I could stay and hear the rest of it, but I will definitely be listening from afar, and we're gonna stay in touch. Thanks a lot.
Thank you, Dr. Berwick. So what we're going to do is take two brief questions before we wrap up, and then we'll invite you to continue the conversation. So we've got one here, and we've got one in the back of the room. Lena, when you're done, there's one in the back of the room as well. Okay. Yes, ma'am.
Hi, I'm the caregiver of my mother. In '93, she was diagnosed with cancer, and it returned in '97 as stage 4. She was given 6 months to live. She is still alive. It's been 14 years, so she has survived a great deal, obviously. But among other things, she's also survived some mistakes. So she survived misdiagnosis at that 97 reoccurrence. She's survived multiple infections acquired at hospitals. And recently, 2 years ago, she, and still exists, a bed sore that was transmitted at a hospital. We, on behalf of her and myself, I'm wondering what concrete steps can we do to improve patient safety?
That is a great question. So I'm going to open it up to panelists, and I'll tell you my own reactions quickly, and then just allow others to add to it. So I think one of the purposes of today is absolutely to begin a community discussion in Cincinnati about concrete steps that we can take together moving forward. It is not about beating up on healthcare professionals. Dr. Berwick is well known for talking about human frailty and the role they play in systems of care, and that we all do make mistakes, but yet we can design systems that will prevent by far the majority of those errors. So if we begin to put patients and family members at the table, you heard Karen talk about the Patient Family Advisory Council approach, sitting on committees for hospitals, but also for physician practices. So I think the most concrete thing to do is begin to talk to the healthcare providers in this room about how you can get involved. And the next most concrete thing to do, in my view, is talk to your healthcare providers or your mother's healthcare providers and ask them, how are you getting feedback from patients and families? Because there are lots of options, and we've put a handout in your packet for getting feedback and incorporating that as a way to improve care. And then also sign up and be part of the Ohio Campaign for Better Care and the national campaign so that we can move this agenda forward together. So we had a question in the back, I think, and then we'll wrap. Yes, sir.
Good afternoon. My name is Bishop Stephen A. Scott, and I have two quick questions. One, I heard nothing about retired veterans and what kind of care they can receive within the program confines of what you're trying to do.
Okay.
I retired myself as superintendent of plans and operation for the medical center at Wright-Patterson. I'm also a cancer survivor. And I find that for our returning military, for our military that have aged, they have very little care and preventive care. I don't hear a whole lot of talk about prevention. I don't hear much about the training of home health care aides and things of that nature. This needs to be taken into consideration.
Sure.
I don't care if you've got the best system in the world. If you don't have people that really want to do what they're doing, then the people that are not in the hospitals are not going to get the help that they need. They're not going to get the type of professionalism addressed to them as they would in some other instances. A lot of time it's just who you know whether or not you get the help you need.
Well, and that's exactly the dynamic we're trying to change. And it's a great question. And actually, the VA and also the Department of Defense, both, for both current active duty and for our veterans, have some, and are rolling out as we speak, some really important programs to include feedback from veterans, patients, family members in their systems of care. So we'd be happy to connect those with you. So we're out of time, and we didn't have quite as much from the panel, I'm sorry, as we had hoped. But again, I want to invite you to stay and talk with each other. What I heard today was really an acute need for doing this kind of work, but also a lot of opportunity, and as Don Berwick talked about, a lot of optimism. There are a number of hospitals in the room who have signed the Partnership for Patients Pledge, and I know the Christ Hospital is announced that they have just signed the pledge. So I want to close by recognizing those healthcare providers who are brave enough and optimistic enough to want to join in partnership with consumers, and to thank them for being here today and for their leadership, and to thank all of you for being involved in and excited about and willing to move this work forward. So thank you.
Sure. Folks, if you can, please fill out the evaluations. And for everybody who's here, you will hear follow-up from us. Thank you so much.